All right, thank you. Good evening and welcome to Personalized Medicine, Are We There Yet? An educational webinar presented by the Northwest chapter of the Crohn's and Colitis Foundation of America. One moment. There we go. My name is Kathleen Waite and I will be your moderator tonight. I'm the Regional Education and Support Manager at the Crohn's and Colitis Foundation of America in our Northwest chapter. I've worked at CCFA 5 years and I've had Crohn's disease myself since I was 11 years old. So we will go over a couple of things before we get started, just to point out a couple of functions in the webinar program to help you interact during the presentation. So first off, as I mentioned a moment ago, you can raise your virtual hand by clicking the cartoon hand in your toolbar on the right side of your screen. We may ask for a show of hands to ask how many people have had a certain experience or something like that. So let's try that again now. Go ahead and raise your cartoon hand. Great. Excellent. Alrighty, thank you. I'll put those down. The other function is asking questions. If you have a question during the talks, then you can type it into the question box. And at the end of the presentation, I will read the questions out loud and answer for everyone to hear, and Dr. Afzali will answer for everyone to hear. And this is also a good way to communicate with me while Dr. Afzali is presenting in case you encounter any technical issues. We will be recording this presentation and we'll email out the link to the replay link to all registrants once that is ready. Now it's my pleasure to introduce tonight's speaker. Dr. Anita Afzali is a gastroenterologist and the director of the Inflammatory Bowel Diseases program at Harborview Medical Center. Dr. Afzali received her medical degree from the University of Washington School of Medicine. She then completed her internal medicine residency and a gastroenterology fellowship at the University of Washington. While in fellowship, Dr. Afzali worked in outcomes research and epidemiology and also graduated with a master's in public health. Her subspecialty training includes a 1-year advanced IBD fellowship at the University of Washington prior to becoming faculty at UW Medicine. Dr. Afzali volunteers on the National CCFA Professional Education Committee, the CCFA Northwest Board of Trustees, and she is the chair of the Northwest Chapter Medical Advisory Committee. Thank you, Dr. Afzali.
Good evening, all, and thank you, Kathleen, and thank you to the CCFA for the invitation to be able to participate in today's webinar. Just as Kathleen reminded you, I hope that this webinar will be very interactive. Please make sure to use the questions, raise your hand if you need clarification, and we will make sure that we are all on the same page throughout the whole part of my program. So tonight we'll be talking about personalized medicine and inflammatory bowel disease. I do have disclosures with different industries that I participate as a consultant as well as an advisory board for, including AbbVie, UCB, and Takeda. Before I start my presentation, I do want to bring a reminder to all of you to my Crohn's and Colitis Foundation Awareness Week. This is the Awareness Week from December 1st through to the 7th. So tomorrow's the last day of the week of awareness. I hope that you will use tonight as another opportunity to learn, teach, and share. Please help educate and raise awareness about Crohn's and colitis. You could also join me on Twitter at IBD Afzali, and please make sure to use the hashtag IBDVisible to try to make sure we raise as much awareness as we can regarding Crohn's and colitis. So let's start. What is personalized medicine? Over the next hour, I hope to be able to talk to you about personalized medicine and whether we're there yet in the practice of personalized medicine for inflammatory bowel disease. Let's first introduce the concept of personalized medicine. Well, there's no single definition for what this is, but this concept was initially introduced in the early 1970s with the hope to be able to provide optimal medical care by using a comprehensive pathophysiology-based information to ultimately be able to prevent, diagnose, and treat disease. The thought is that the approach is custom made for each individual patient. Now, this concept in the early pre-2000, year 2000, as far as the amount of studies or research committed to personalized medicine, PubMed is the resource or research database that's used to evaluate this. There was at most about 100 articles related to this. In 2014, you can see that the art of personalized medicine, or the practice of it, has certainly increased, and now up to about 4,000, if not more, among research and studies to be able to evaluate the effectiveness of the practice of personalized medicine for a number of different chronic diseases. So what is personalized medicine? Well, ultimately is trying to be able to identify the right patient for the right treatment at the right time. And it's an integration of clinical variables such as age or gender, putting that together with disease characteristics, components of genetic, for example, as well as conventional laboratory testing or other forms of testing, whether it's endoscopy or imaging, to ultimately help guide treatment decisions. The hope is that with being able to identify and bring in these different variables, we can decrease risk of adverse events and complications, and ultimately be able to optimize the outcomes for this disease. Now, the art of personalized medicine, or I should say the practice of personalized medicine, has already been applied for other chronic diseases such as diabetes and hypertension. And what I hope for you to understand tonight with my talk is that I would like us to start being able to apply personalized medicine for inflammatory bowel disease. And why is that? Well, you may already have heard of the spectrum of IBD. And really the spectrum, as it has been introduced to all of us in the past, has been as follows. It's either Crohn's disease, ulcerative colitis, and there's a few of us who may have what we call indeterminate colitis. But is it really that simple? Or is it more like this image, where there are so many different subtypes and phenotypes, meaning how the disease presents? So really, there's not just the 3 circles, but as you can see here, there's a whole spectrum in inflammatory bowel disease. And why is that? Well, there is a complex interaction between different components of what ultimately leads to inflammatory bowel disease, and we label these as the OMS in the inflammatory pathogenesis of inflammatory bowel disease. We can start with the immunome, so already a dysregulation of the immune system, as far as having a large increase of pro-inflammatory proteins. There's the microbiome. We are made more of bacterial and other species in our gut than we are of human skin cells. So there's an interplay with the microbiome. Then we have the exposome, and these are a countless number of different environmental factors, whether that's prior use of antibiotics, smoking, even diet, for example, can be one of those triggers or environmental triggers that can relate and ultimately result in inflammatory bowel disease. And then there's the genome. To date, we've identified over 160 genes that have been found to be associated with inflammatory bowel disease, but I caution you with that, it's not causal, which means we have not identified a gene to say that if you have or don't have this gene, then you will get IBD. But from this diagram, you can see that any form of interaction between one or many of these OMS will ultimately result in a disease called inflammatory bowel disease. So when we know that there's this complexity in a number of different ways that interactions can occur, then certainly we can conclude that certain disease subtypes will occur in certain patients, certain individuals. And that how one patient presents with their disease is not how another patient will present with their disease. So why do we need personalized medicine in inflammatory bowel disease? Well, it's just like I discussed, or as this comic says, one size fits all, except for you, of course. And we all know that one size does not fit all. So we have to stop assuming that one treatment, one approach, or one disease is for all. And that is what personalized medicine in inflammatory bowel disease is. So knowing this complex interaction, any and all of these which could ultimately lead to inflammatory bowel disease, we have to understand what is interacting with what to ultimately lead to your disease. So let's go back a little bit. Inflammatory bowel disease. Well, we know it's certainly a dysregulation of the immune system. And for some of my patients who are actually logged on will know that I've used this example with them directly in clinic as well. Our immune system. What is the immune system? Well, imagine one of us walking and we fall and we get a big cut on our knee. Well, it's our immune system that immediately turns on to prevent any form of potential infection to enter at the site of the knee and ultimately into our blood supply and towards our heart, brain, etc. Now, once the immune system turns on, it fights any potential infection. So what happens at the knee? Well, of course, it's painful, it's warm, it's swollen. All these symptoms that occur or signs that you see at the site of the knee, it's different proteins involved in your immune system, pro-inflammatory proteins. And once this area has helped heal over time, our immune system knows how to turn off. So these pro-inflammatory proteins and cytokines now turn off because our body doesn't need that protection anymore. But the problem with inflammatory bowel disease is that this on-off switch is broken. And therefore, inflammation is a key aspect of IBD because of this dysregulation of the immune system. Now, you've all either been exposed to or know of these different IBD options in therapy. This is our medicine cabinet, from the over-the-counter therapies such as an antidiarrheal to antibiotics, where you may have had to require antibiotics, for example, if you had an abscess, to 5-aminosalicylates or mesalamine products. Examples of this, for example, are Lialda or Azicol or Pentasa. And then there's this prednisone and budesonide. So these are steroids. And then we have our immune modulators. Some of you are also familiar with these. These are medications such as azathioprine, 6-mercaptopurine, Imuran is the trade name for the azathioprine, as well as methotrexate. Now notice that I highlighted these therapies from the over-the-counter all the way to the immune modulators in red, and then we have a different treatment class of medications, and these are our biologics. And these are our protein-targeted specific treatment options, which we will talk about. Now, before we go to the biologics, I do want to bring a reminder to you that in regards to the mesalamines, the steroids, and the immune modulators, we don't know how or why it works, but we know it works. That's in contrast to our biologics. Our biologics are target specific to specific proteins, for example. TNF is a perfect example. The specific genetic defects is what we're hoping to in the future, or even microbial imbalances. But biologics are target specific proteins at present that we have available, such as anti-tumor necrosis or TNFs, anti-adhesions, anti-interleukins, I should add up there as well. These are protein target specific treatment options. And so they directly target what is responsible for the disease process involved in the inflammatory cascade for your inflammatory bowel disease. So you can see here that there's a list of pro-inflammatory, which causes inflammation, and then there's anti-inflammatory, which decreases the inflammation. Having the potential to target any of these, either being able to target the pro-inflammatory or the anti-inflammatory, you can see that these are potential options for the future to be able to determine whether or not we could have a future potential biologic agent. This is a summary of anti-TNFs, one of these biologic classes or mechanisms of action, and these are the anti-TNFs. You can see from early 1998 when the first biologic was approved for Crohn's disease. This is infliximab or Remicade. Since then, we have adalimumab or Humira, We have certolizumab, which is Cimzia, and we have golimumab, which is Simponi. And you can see that these are all protein target specific anti-TNF agents. Since the anti-TNFs, we've also have newer mechanisms of action, newer targets for our biologics. And one example of what recently came out in 2014, which is vedolizumab or Entyvio, as well as recently ustekinumab or Stelara, which has been approved for Crohn's disease just recently. So again, target-specific proteins that are able to target specifically the inflammatory cascade under a special mechanism of action. And with these biologics, we know what we're targeting to try to improve the inflammatory cascade. Biologics have revolutionized the treatment and management of our patients with ulcerative colitis and Crohn's disease. Why do we use them? Well, our results consistently have been found that these therapies are very effective. Our biologics have been able to decrease need for hospitalization as well as surgery, and I'll show you a slide on that. We've been able to achieve what's called steroid-free remission, which is we keep you off of the prednisone. These biologics have consistently demonstrated an improved quality of life for our patients. And specifically, we've been able to change the natural history of this disease. And I'll show a slide on that. What are some limitations to the use of biologics? Well, certainly there's cost, as well as misinformation in regards to the side effects or adverse effects. And so these can absolutely be limitations for the use of it. So inflammatory bowel disease, be it Crohn's disease or ulcerative colitis, is very similar to other autoimmune diseases such as rheumatoid arthritis, as well as a disease of multiple sclerosis, different lung diseases, and we'll categorize that as asthma, as well as a skin disease, for example, called psoriasis. You will note that over time, our therapies that we currently use, or some of our therapies that we currently use or have been using for the treatment and management of Crohn's or ulcerative colitis, has previously already been used for some of these other diseases. The same biologic agent, because it's for all of these diseases, there's a dysregulation in the immune system, either causing joint disease called rheumatoid arthritis or bowel disease called inflammatory bowel disease. Same process, but we're utilizing the same biologic therapies. So knowing that, let me start with giving an example of why I always bother my bone doctors, our rheumatologists, and say that they have it easier. And why do I say that they have it easier? Not because joint disease is an easier disease to have, but it's an easier disease to recognize. And what do I mean by that? Well, anti-TNFs, the biologics that we talked about, for example, infliximab, Remicade, has been previously used and it has consistently been used, for example, in rheumatoid arthritis for this joint disease. Now, our rheumatology, our joint doctors, are able to see this disease progress, as are our patients. For example, here early on, there's just very, very mild swelling at the knuckles to a little bit more swelling, and there's more pain, of course, that the patient tells and reports to their doctor, a little bit of deformities to such severe deformities that you can see on the later stages of rheumatoid arthritis. Now, what the joint doctors, the rheumatologists, have been able to demonstrate with a target-specific anti-TNF agent, and in this study it was infliximab or Remicade, they were able to demonstrate that with early appropriate treatment with a biologic to appropriately target the inflammatory cascade as an anti-TNF agent, compared to placebo, patients who received early appropriate therapy over time were less likely to have advancement of their bone disease. We have been able to demonstrate similar findings for inflammatory bowel disease, recognizing that if early on we treat our patients with appropriate biologic therapy, and in this study, for example, it was certolizumab or Cimzia, you could see that those who were treated early on do better, achieve a good response, as well as maintain that response called remission compared to placebo. Again, emphasizing that early on, our patients will do better if they receive appropriate therapy early on. And I want to emphasize timing to you. And if we were to scope our patients and be able to see this difference, you can see that here's that before with these ulcers, the swelling, the thickness of the colon to healed mucosa. And this is just some stool, nothing to worry about, but this is healed mucosa, no ulcerations, nothing. And so we know that if we target the inflammatory cascade, for example, in this an anti-TNF, we can improve the inflammation and result in healing. Now, the problem, and this is why I say our rheumatologists have it easier than us as gastroenterologists, is that we don't see the deformities of the intestines, unfortunately, until a complication occurs. So for the rheumatologist, you as the patient sees it, your doctor sees it, everyone knows this is getting bad. But the problem with inflammatory bowel disease is we don't see how bad it could get, but we know how bad it can get. So you can see here, for example, that chronic inflammation can lead to such severe inflammation where now there's an abnormal communication or connection between different parts of the intestines, for example. There's such inflammation that now there's scarred down tissue causing narrowing and ultimately an obstruction, meaning that stool is having trouble passing through, to even a hole or a micro perforation that can be built or be created because of chronic inflammation. And what else do we know? From this graph, you can see that although most patients initially present with active inflammatory disease, so most patients over a 20-year time frame, you can see here that from the initial time of diagnosis, over 20 years, they will initially present with active inflammation. But what happens over time? Well, now over time, they're more likely to progress to stricturing, which ultimately leads to the obstruction as per the prior slide, as well as penetrating, which is that abnormal communication or fistula. So although initially, sure, there is about 20% of patients who will initially have a fistula or stricture, the majority of patients initially when diagnosed with Crohn's disease will have active inflammation. And active inflammation can be treated with target-specific active appropriate therapy. But over time, if we don't target this appropriately, then now the risk of progression to surgery increases because this here, stricturing and penetrating disease, this type of disease phenotype or the characteristic does not really improve with treatment. This unfortunately becomes a surgical indication. And we see this. This is a graph showing that the natural history of Crohn's disease over time, from the time of diagnosis, over years of having this disease, if left untreated, the need for surgery increases over time. And similar to that for ulcerative colitis, if left untreated, the risk of needing surgery over time also can be anywhere from 20 to 30%. But this is a beautiful graph to remind us that we've been able to change this history of inflammatory bowel disease. This is a slide demonstrating the trend for the need of what's called a colectomy, which is removal of the colon. And you can see that since about 1998, the need for surgery for a colectomy, remove the colon because it's so actively inflamed, now has decreased. And this has been coincidentally since the introduction of appropriate therapy, and these are our biologics. And in this study, it says this study, when it was evaluating, it was specifically for anti-TNFs, one class of biologics. So that's a little bit of a background, but how do we identify the right patient? If we're talking about personalized medicine, how do we first identify who the right patient is? How do we choose the right patient of who needs early appropriate intervention? Well, we've been able to identify certain factors which may help predict that you are at a higher risk or likelihood for your disease progressing. From this, you can see that being male gender, for example, younger age, having the disease for a longer duration of time, based on where your disease is located, smoking, having perianal disease, requiring steroids at the initial time of diagnosis. These are some factors that have helped identify for us as providers of, okay, who's at highest risk for disease progression. And you can see here that having 2 or greater factors, the ones I listed out on the prior slide, you're at a greater risk or need for now what we call the positive predictive value of you are more likely to have disabling Crohn's disease. And what do I mean by disabling? I mean more complications, more likely to develop strictures, more likely to develop fistulas, more likely to require steroids, be hospitalized, be malnourished. We've also identified additional markers, for example. So these are some genetic and serologic markers where we've been able to say that now with this, we've been able to test additional factors. And here you can see that there's ASCA, there's ALC, Seberflax, FLA2, P-ANCA. These are just some serologic markers, some blood tests, for example, that helps us predict, okay, you're more likely to have maybe Crohn's disease or more small bowel disease or be at a higher risk for surgery. So you can see here that some of these markers, more likely small bowel, more likely complicated disease, or more likely ulcerative colitis, or more likely to have recurrent pouchitis. And some of you may be already familiar with that. So we have different serologic or lab tests that helps us identify who is at a higher risk for disease progression or disabling disease. And we know from this graph that if you have more of those serologic markers that I demonstrated to you on the prior slide, you're more likely to require surgery, for example. So this is a list of some of those factors that I described to you earlier, as well as some additional ones. And you can see that we've been, over time, we have been able to better identify who's at risk for more aggressive disease. So for Crohn's disease, again, some of the factors I mentioned, some of these serologic or blood factors that we've talked about, smoking, I really want to emphasize this. If you have Crohn's, stop smoking. You are only hurting yourself further. So absolutely, when we talk about variables associated with more aggressive Crohn's disease, these are some factors that we look at to see or help us predict if you need to be on appropriate therapy early on. And when we talk about appropriate, we need to target that inflammatory cascade as soon as possible before the inflammation decreases, but now you have scar down tissue. And really the most important factors we look at is disease location, the extent of disease, as well as the depth of the inflammation or the lesions that we see, which suggests that you're at more higher risk for developing a stricture, for example. And then on this other side, you can see for Crohn's disease, again, several factors. If you're younger, if you have your whole colon involved, if you have a liver disease along with your Crohn's, with your ulcerative colitis, PSC is the liver disease. If you're still not improving despite initial therapy, if you have bad inflammation, and then there's that serologic marker that I described to you earlier. But really, what we look for, and again, the most important predictors for us is how extensive is your disease, when did you first develop your disease, and how responsive or not responsive were you to the prednisone or the mesalamines, such as that Lialda or Azicol or Delcicol, for example, or the enemas even, for example. So we talked about the right patient. What about the right treatment? If you are at high risk, if you do have some of these factors, how do we choose the right treatment? Well, some of you, and perhaps even yourself and your doctors, have already talked about these different strategies or approaches. There's what's called the step-up strategy, which is, okay, let's start with let's go sequentially upwards. Initially, I present with mild disease, and then if I have moderate, then you advance my therapy, and then if I'm progressing, then you will consider surgery, and only then would you maybe also consider a biologic. So that's called the step-up approach. This is, again, a sequential treatment for trying to achieve remission and maintain that. It's found to be more cost-effective because you're starting with some of the less expensive therapies, such as the mesalamines, and perhaps minimal side effects. Then there's the top-down strategy. The top-down strategy emphasizes early appropriate therapy, and previously the word here was called early aggressive therapy. We've started to stay away from that term. Maybe I should say I stay away from that term because I don't find it aggressive. I find it appropriate based on the variables and factors I described to you. So in the top-down approach, the approach is let's start early with appropriate therapy with either biologics or biologics in combination with an Imuran or azathioprine or 6-mercaptopurine or methotrexate. And during this time, we may also need to try or consider the use of steroids if we need to induce rapid clinical response that was initially not achieved with the biologics alone, but only later and only over time do we need to or should we want to consider surgery, again, if we're unable to achieve good mucosal healing or if the disease in and of itself has progressed to fistulizing or penetrating or stricturing disease, then we consider surgery. But early on, we start with appropriate therapy, specifically with the biologics and or combination treatment. Now, the problem with these treatment strategies is, of course, the step-up strategy. So this lower part, the step-up strategy may postpone the adequate therapy for those who have more aggressive disease. If they had some of those variables that I described to you earlier, then they're at a higher risk for disease progression. They're at a higher risk for complications and morbidity. And so, of course, we have to be cautious of this group, that if we took that step-up therapy, were we delaying appropriate treatment for them? Then there's that top-down approach, and among those, what if we're over-treating? What if we're overexposing some of our patients to treatments that maybe they don't have as aggressive of a disease, and maybe we're over-treating? There's that concern, of course, the risk of immune suppression and other side effects that we're absolutely concerned about when we talk about our biologics. And then there's the cost of therapy as well. And I just added this slide about a few minutes before this talk because I noted that someone had a question in regards to understanding what some of these side effects or risks related to our biologics are. And we could discuss this at the end of the talk further. But this is just a quick reminder of a slide that and specifically for some of these adverse events or side effects related to our biologics, the risk of anti-TNFs as well as our immune modulators. So this is your azathioprine, your methotrexate, your 6-mercaptopurine, for example. Methotrexate, I'll take that out because we don't include that as these side effects. But as you can see here, if you had 10,000 patients who were treated for 1 year with an anti-TNF or a thiopurine, so specifically azathioprine or 6-mercaptopurine, the risk at baseline without ever being exposed to these therapies for non-Hodgkin's lymphoma, which is the cancer that certainly we are concerned about, without being exposed to our therapies, the risk is 2 out of 10,000 people without being on these therapies, without having inflammatory bowel disease, 2 out of 10,000 people will get this cancer called non-Hodgkin's lymphoma. Now, the risk for non-Hodgkin's lymphoma among our patients who are on azathioprine or 6-mercaptopurine alone, that risk increases to up to 9 out of 10,000 people. So from the baseline, about doubles. Then you say, well, what if we add a biologic? And among those, these patients were also previously on a thiopurine, so on azathioprine or 6-mercaptopurine, similar risks. A very rare type of lymphoma, we can't even really say how frequent we see this, but it's very infrequent. These are about less than 1%, so this is even less than 1%. Death from sepsis, so such severe infection, 4 out of 1,000. I don't know if this is related to our therapies or if this is related to such bad disease. And again, having severe inflammatory bowel disease in and of itself, you have a dysregulated immune system. Your body is unable to be able to even fight typical infections potentially as well as it should or would want to. And specifically for tuberculosis, this is why we always check your TB status before we even initiate therapy. This risk is about 5 out of 10,000. So I want to put this slide up because, again, I want to really show you some numbers when we talk about these risks. And though I don't want to minimize the risk, I certainly want to remind you that these risks are very low or uncommon. So back to our treatment strategies, whether we talk about the top step up or top down approach, I hate looking at it like that. Let's look at it more like this. Let's look at it as, of course we want to improve our symptoms. Of course we want to achieve what's called clinical remission, which is you feel better. Of course we want to get you off of the prednisone, the steroids. But more importantly, the core of where we should be headed to with our therapies is what's called mucosal healing, and ultimately what will be our dream is histologic remission, which is on a cellular level, have we just stopped the inflammation? These should be our goals, and these, of course, also are our goals. So instead of looking at it as top down, step up, let's see how well we're able to achieve all of this, if not most of it. And what we know is that compared to our other therapies, this is the SONIC trial showing us that compared to placebo, so the sugar pill in combination to azathioprine or Imuran, compared that to another group of patients who just got a biologic, and in this study infliximab or Remicade, and compare that to a group who got both Remicade or infliximab and Imuran or azathioprine, you could see that those who got what's called combination therapy were able to achieve steroid-free remission. They're able to remain both clinically better and mucosal-wise better compared to placebo and or azathioprine alone. Similar, you could see that for ulcerative colitis. This is a success trial, another landmark study for us as gastroenterologists. When we look at data, we see that for steroid-free remission, as well as mucosal healing, as well as response. So again, those targets for where we should be looking at when we see if and determine which approach we should take, you can see that combination treatment with a biologic and an immune modulator such as azathioprine or methotrexate or 6-mercaptopurine does better compared to placebo or alone. So combination therapy, we know that it helps achieve better clinical outcomes. We know that with addition of a concomitant agent, we know that we help improve the response rate to the biologic therapy, right? So the prior slide showed you that the biologic alone versus the biologic in combination to an immune modulator, those who were in concomitation treatment did better. There's always also the reduced risk for antibody development to the biologics. And lastly, there's a decreased need for steroids when our patients are on biologic in combination to an immune modulator. So we talked about the right treatment, but what about the dose? Well, one size doesn't fit all, so why do we think one dose is for all? How do we choose the right dose? Well, we know from how these therapies work, this is the pharmacokinetics. We know that there are certain factors that will either help make our biologic agent work better or less effective. And we know that the drug, the biologic drug, for example, in this study, the anti-TNF, works less efficacious if you're male gender. Body size impacts it. Your nutritional status impacts it. If you have a high amount of inflammation, and for example, CRP, if this is really, really high, you're less likely to absorb the biologic agent and less likely for that drug to work. Smoking reduces the efficacy, how well the biologic works. It reduces it, so it doesn't work as well. The presence of antibodies. If you've developed resistance to the biologic agent, then of course there's less drug available because the drug is being eaten by the antibodies, which is trying to attack the drug or the medication. Having high amount of inflammation, specifically TNF levels, so certainly when there's a lot of TNF, there's only so much anti-TNF medication that could go around to attack this. And then here we know that with combination therapy, we improve the biologics because there's now more drug available for the body to utilize. So how do we optimize the dosing? For the patient who's on early appropriate treatment, how do we optimize our treatments? Well, we have this both, we can optimize this by checking levels, drug levels, for example, both for our patients who are on an azathioprine or 6-month captive period, as well as for patients who are on anti-TNFs. This is another utilization of pharmacogenomics. We can do a testing, we could utilize the genetic testing to best optimize our medical therapy for our patients. This genetic testing, TPMT, or thiopurine methyltransferase enzyme activity level, I won't bore you with the details, but to call it TPMT, we know that if you have the right gene for this, you are more likely to do well with our therapy and not have side effects. Conversely, if you have a mutation of this gene, you're more likely or at higher risk, I should say, for having toxic levels and also from having side effects related to when you take azathioprine or 6-mercaptopurine. And we also can check levels of this. We know, for example, that perhaps you don't have enough of the drug in your body by checking levels. So these are 6-TGN and 6-MMP are the metabolites of the azathioprine. So we know if you're even taking your therapy, right? So if we have really, really low levels of 6-TGN and really no levels of this other metabolite, I'm probably going to give you a call and say, hey, are you even taking your azathioprine? We know when it's potentially causing more problems, and we also know that you're at a higher risk of just not responding to the azathioprine, so we may not even give you more azathioprine. And then let's talk about therapeutic drug monitoring for biologics. Well, specifically for anti-TNFs, what we know and what we've learned over the past several years is that about 50% of our patients with inflammatory bowel disease will require some form of modification to their biologic agent, usually within even 1 year, either because they're now needing a higher dose or a more frequent infusion, for example, or they're requiring to switch to therapy because perhaps they've developed resistance or a loss of response to treatment. Not just that, but we know that in general, about 30% of our patients will never respond to this particular class of biologics called anti-TNFs. And we also know that therapeutic drug monitoring is important because our symptoms don't relate to what we see as far as active inflammation, whether that's based on endoscopy, imaging, or laboratory testing, which we'll talk about. So therapeutic drug monitoring for biologics became important because we need to be able to identify who just doesn't have enough of the medicine, who's developed resistance to the medicine, and among those, who is potentially developing or having symptoms other than the cause or related to their IBD. For example, what if they're having symptoms related more to what's called irritable bowel syndrome or IBS? What if they have a stricture that no therapy will really treat and they need surgery and perhaps their medicine's working to prevent future inflammation, but that scar down tissue still needs to be removed or resected, so surgery. What we know from therapeutic drug monitoring is that having more drug levels is associated with lower inflammation based on a lab test called CRP, which you may be familiar with. We also know that if you have antibodies to your biologic agent, in this study infliximab or Remicade, you can see that if you've developed resistance to your biologic, you're more likely to have more inflammation or higher CRP. So what do we do with this therapeutic monitoring for our biologics? Well, we know that if you have high detectable antibodies to the biologic, us continuing your current biologic is probably not a good idea, and it's perhaps a better option to change you to another biologic. And specifically, if you initially did well with one anti-TNF, you may benefit from trying another anti-TNF, just changing it from, for example, Remicade to Humira or Cimzia, etc. What if you have a subtherapeutic anti-TNF drug level? So a subtherapeutic biologic level. What do we do for those patients? Well, we know, just like I said to you earlier, one dose isn't for all. So perhaps maybe this patient has certain factors that's basically preventing their body from responding to the dose that they're at, and they need more dose of the medication or of the drug. So in this situation, based on our levels that we check, we would increase the dose or the frequency of their biologic. But what if they have a normal drug level and no antibodies? Well, this is a good reason for us. Again, why do we do therapeutic drug monitoring? Because we want to optimize your therapy. And if so, you're currently on a biologic agent, and then you're developing active symptoms, and I check a drug level and antibody level, and I see that you have appropriate drug level and no or very low detectable antibodies, I'm more likely to ask that we do another scope, and we obtain laboratory studies, and we do image studies to really evaluate for active or inactive disease. If there's active disease, based on what I see, these other objective findings, then I'm more likely to switch you to a different class of biologics. So again, not just an anti-TNF to another anti-TNF, but perhaps I would switch you to a different class, a different mechanism of action, as we talked about earlier. So the right time, we talked about the right patient, we talked about the right treatment and dose. What's the right time? Well, timing is everything. So let me bore you and show you a little bit of example of another disease, just to remind you of why timing is important. And again, for my patients who are logged on, you've heard me give this example. Let's talk about heart disease. You know heart disease, I know heart disease. So what are some factors that tells me that, or tells the cardiologist, the heart doctor, that you're at a high risk for an MI, a big heart attack? Well, certainly obesity, fast foods, diet, etc. Absolutely high cholesterol. If you have diabetes, you're at a higher risk for heart disease. If you have high blood pressure, you're at a higher risk for heart disease. If you smoke, you have a higher risk for heart disease and a big heart attack. And if you have a family history, you're at a higher risk for heart disease or a heart attack specifically. So which cardiologist, with knowing that you have all of these factors, will only give you a baby aspirin and not ask you to treat or try to treat or target these other factors, right? We wouldn't just give you the baby aspirin and wait for that big heart attack to happen and then treat you with early appropriate therapy. Using this concept, the same goes for inflammatory bowel disease. We know that symptom relief is not enough. What do I mean by that? Well, how you feel before or after starting a treatment, unfortunately, it's only subjective data. We still need what is called objective data to really identify and see what is your disease trying to do over time. Objective data such as laboratory tests, and I want to remind you that about 20% of the population does not mount a CRP or ESR response, meaning that you could have active inflammation but normal inflammatory lab tests. But we have other objective tests such as endoscopy. We have radiologic tests such as a CAT scan or an MRI. So these are objective tests to be able to evaluate the burden, the inflammatory burden of your disease. And why is this important? Well, again, I want to remind you how you're feeling has unfortunately very little correlation or association with what we see when we scope you, for example. So this is our scoping score. This is a score telling me what your symptoms are like, are at that current time, for example. And when we put it on the map, you could have severe disease but very mild symptoms, and conversely, you could have severe symptoms but very mild active inflammation of what we see. So when we go back to timing is everything and really trying to understand what your disease is trying to do over time, Yes, we could take that approach from that heart disease and just do a very mild approach, but if you have progression of your disease and over time, if your disease is trying to become more stricturing and penetrating over time, then perhaps we're doing more harm with not starting early appropriate therapy. So if initially we just ask you to modify your diet when you initially are diagnosed with inflammatory bowel disease, and then over years, you can see here from this map, that over years then perhaps we'll give you some oral tablets, we'll give you a few courses of steroids and see where that will take you. And then now years later, you're already here on the graph, years later we're going to start you on a biologic agent or early appropriate therapy with a combination treatment, for example. Well, what's going to happen? This is the natural history of the disease. If we delay appropriate therapy for those who have some of those predictive factors or variables I identified to you earlier, we're increasing your risk of needing surgery. So this is why it's important. This is why personalized medicine in inflammatory bowel disease is important. We need to be able to identify who is the right patient, what is the right treatment, and when is the right time. And this is the art of personalized medicine in inflammatory bowel disease. So how do we put this into practice? Well, we absolutely need to be able to better understand your fears of our therapies and our approach to managing your disease. We need to be able to address them as in partnership and really be able to have that physician-patient relationship so we could address your concerns and correct any misinformation. And sometimes maybe you need some further clarification on what is my risk for cancer, for example, or what is my risk for whichever and whatever your concern is. Ask your doctor directly those questions. And then next, it's very important when we're talking about putting personalized medicine into practice, it's very important early on for us to be able to have good objective data, to be able to monitor that objectively, either by endoscopy, for example, by imaging, by certain biomarkers, including CRP and calprotectin, which some of you are familiar with. And then it's also important for us to not only identify what our objective early markers or different approaches should be of how to best monitor the disease, but then you and I, so the physician and the patient, need to also agree on when will I be reevaluated. Again, I reminded you, symptoms don't correlate with how and when your disease progresses. So that question needs to be asked, when will we reevaluate? When do we see if this treatment is working? Or perhaps when do we stop this treatment? So again, understanding what that time frame should be early discussed as soon as possible with your providers. So this is an algorithm that has been proposed and I follow in my clinic for my patients. So initially, if there's active disease, I risk stratify them. So at the top you can see, so when I see my patients, I already, in my head, I have identified certain factors that places them at either a higher risk or not so higher risk for disease progression. I start whatever treatment based on how high risk they are for treatment. So I decide treatment based on how high risk they are for disease progression. So again, if they don't have those different factors or variables, if their disease and their inflammation is very mild, I may still just start lower on that step up or top down approach and may just do a mesalamine. But if they have those factors I've identified to you, these are patients I absolutely want to give them the best opportunity to respond to treatment. And these are patients that will require early appropriate therapy, for example, with combination treatment with the biologic and an immune modulator. Then after 2 to 3 months, I've already discussed with my patients that we need to reevaluate. Is it working? Definitely, we don't let it go longer than 6 months. Then we talk about what our targets are. Not only do we want to improve symptoms, absolutely, that's important, but what are the other targets? Well, were we able to improve laboratory values? Were we able to improve or achieve mucosal healing, if not remission, right? So we need to be able to identify what our true targets are. If yes, we continue with the therapy because we know what the natural progression, unfortunately, of this disease is. If we have not been able to improve these targets, then we have to talk about how do we switch or optimize the current therapy in order to achieve a good response to our treatment regimen. So the approach to personalized medicine, wouldn't it be great to be able to walk into a clinic and say, I have this type of disease, this is my disease genotype and my phenotype. So this is how I'm presenting with the disease, this is my genetic makeup of the disease, and we will be able to, as providers, be able to identify that early on and say, yes, this is how, and these are what your chances for aggressive disease or disabling disease is. Would we be able to say these are your chances for progression of your disease and then find the best treatment? Well, this is certainly where we're headed towards, and this is the art of personalized medicine I've been describing to you over the past hour, which is to be able to have just this approach, trying to understand your disease and trying to find patient-specific treatment with the least amount of side effects for you and also with improved and best outcomes. So are we there? Bring us back to that initial question, are we there yet? We're not there 100%, but I'll tell you, we're getting very close. We're able to identify a lot more of these factors, whether it's on a genetic level, whether it's on an immunologic microbiome level of being able to identify certain responses to bacteria, whether it's being able to identify your disease type early on, whether you're more likely to have small bowel disease or a fistula, for example. So we've been able to find certain therapies that may or may not best treat your disease. We're not there 100%, but we're getting there. And with that, I'm going to end my discussion, and I welcome any questions you have at this time. Again, you can log on our website as well as find me on Twitter.
Thank you so much, Dr. Afzali. A few questions going in here, and we also have questions on registration. All right,
so the question, what percent of IBD is indeterminate? We say about 10% of IBD is indeterminate, and I say that as we improve our modalities of being able to further evaluate the IBD to see the distribution of the disease, for example, by capsule endoscopy where we have you swallow a little camera, we're identifying better even this indeterminate kind. But for right now, we say it's about 10%. So that's a great question, and thank you for picking that up. That's still in lab testing process, so that's not actively something we could check right now. But certainly, there's different laboratory folks who are trying to design an assay to do this. So I'll go through another question. Is it okay to be on a biologic while pregnant or nursing? And if so, which one is the safest? I'll start with saying that all of our biologic agents are what we call a pregnancy category B. And so whichever biologic you're currently on, and if you are interested in pregnancy and or nursing at that time, continue the biologic that you've responded best to and you remain on. Because what we know is that if we improve your disease activity before pregnancy, you're more likely to do well during pregnancy and even after, as well as the baby. So the baby's more likely to do well. So whichever biologic agent you're on, stay on it. And then if you have achieved mucosal remission and you get pregnant, it's safe, category B. Next question is, do the treatments for Crohn's disease delay puberty? That's a wonderful question. The answer is not so much do the treatments for Crohn's disease delay puberty, but the more important thing that we need to recognize here is that unfortunately Crohn's disease impacts growth and puberty in and of itself. And certainly certain treatments such as prednisone can adversely affect puberty and growth as well. So we need to be more cognizant of the disease impact particularly for our younger patients with this diagnosis of IBD, and the treatment in and of itself, aside from steroids, which we know it impacts growth and development, the rest of the therapies do not so much have a direct effect on puberty. Some additional questions that we have: how do we know if my meds are working for me? I think this was an early on question, so I would say I think I've answered this. Be able to evaluate not just your symptoms, but actual objective data. So really being able to objectively look either by scoping, by imaging, by laboratory tests, and put that all together to determine if it's working for you. Next question is, I'm on budesonide and I've been on it for 5 months. I read it's not good for you to be on it for that long. Is it true? Budesonide is another form of a steroid, a form of prednisone. Now, sure, the majority of budesonide is absorbed by the gut, and so it absolutely has less side effects than prednisone would have, but a steroid is still a steroid. And over time, the effects of budesonide being on that, the cumulative effect of it may still be hazardous. So being on it for a longer duration of time, you have to reassess this with your provider to again ask the question of what are the targets? What are they targeting for your disease? If you still have active inflammation and you're on budesonide alone, how else can we better treat that inflammation rather than just continuing a steroid in and of itself or as a single agent? If the diagnosis is indeterminate, is the treatment the same? Well, in general, yeah. If it's still active inflammation, yeah, we need to treat it the same. We need to address the active inflammation as best as we can, because we may call it indeterminate today and later it may be Crohn's, or we may call someone ulcerative colitis today and later on we are telling them they have Crohn's disease. And so absolutely our target should be active inflammation regardless of whether we want to use the word indeterminate. And when do we use that word? Usually it's when there's colonic disease with very mild or non-specific inflammation in the very last part of the small intestines. Long-term use or concerns for Humira and methotrexate and the future treatments for him coming up. So this is for a patient who's in their mid-20s. Long-term concerns, I think, and I really hope I emphasize to you that the long-term concerns of having active inflammation and progression of the disease to stricturing, penetrating, fistulizing disease is more important for us to focus on than the therapies. The long-term, we have long-term data on our biologics, for example, 7+ years of data on different biologics, and we find that the long-term data looks to be, in general, very safe. And so if you are responding to a current treatment, I would suggest remaining on that treatment because you are really lucky to respond on that treatment for so long without active inflammation. So stay on that treatment that works for you. And as far as long-term risks, I would focus more on if you were off of therapy and you had active inflammation, you had more risk of, again, needing surgery, needing steroids, requiring hospitalization, etc. If I'm on Remicade for 6 years with no current problems, should I still consider another biologic such as Stelara? Again, emphasizing stay on what works for you. You and your doctor need to, in advance, understand what your treatment targets are. And once you've identified those targets, make sure that's the approach you're taking with your therapies. If you have ongoing inflammation with being on a current treatment, that means the treatment's not working. We need to change the therapy. If you don't have ongoing inflammation, consider changing your therapy, and that would be a discussion you and your doctor would need to have. Other than endoscopic viewing or sampling, what are the best serum biomarkers for early recurrent Crohn's disease? Oh dear, I'll tell you, we get asked this question so often because I get it. No one wants to have frequent colonoscopies, and No one wants to be able to go through different imaging studies, etc. But unfortunately, as I mentioned to you, with the current biomarkers that we have, specifically CRP and ESR, which is a lab testing, about 20% of patients who, even with having active disease, they will continue to not mount a rise in their CRP or ESR. And also with the fecal calprotectin, which some of you may be familiar with, that's also another test that works, and certainly it can tell us that there's inflammation. But as far as how bad the inflammation is and the prediction for recurrent Crohn's disease or progression of disease is not so good at. So still right now it's very important to have good targets, and those targets are including biomarkers, but more specifically, and what we have all agreed on, is by endoscopy and imaging at present, as well as your symptoms. Next question is, not all GI doctors specialize in IBD. How do we find good referrals in other cities? Well, I think this is where the Crohn's and Colitis Foundation is very important. This is the best time to be able to encourage you, your family, your friends who are moving to other cities or need to find another provider to reach out to the local CCFA chapter. And our chapter with Kathleen, for example, would be a great resource to be able to say, can you help me identify a provider in this city or in this area? So certainly we have good opportunities for networking and for helping you find the right provider for your disease. Thoughts about biosimilars versus the current anti-TNFs. You guys are bringing excellent questions. Well, I'll start with saying there's so much we need to still talk about biosimilars. I know there was previously a webinar on biosimilars. I encourage you to log on to that. Definitely don't want to take up too much time on answering that, other than we need to be able to have good and more options for our patients. So biosimilars is there, but we need to be able to have balanced research and data and information rather than just extrapolating data and utilizing the biosimilars for all diseases. And you'll learn more about what that means when you log on to the webinar that was previously performed for biosimilars. What treatments are in the horizon? There's a lot. It's such an exciting time. You know, I tell some of my patients that this is the time that we're learning so much more. The IBD pipeline, the drug pipeline, we are coming up with different targets and different opportunities to target the inflammatory cascade. To come is an option such as a oral biologic, for example. We have, here at my institution, I have different clinical trials for this. So there's different target-specific biologics that are in the horizon, and thus far they look promising. So certainly that's something of excitement for all of us.
Great. Thank you so much, Dr. Afzali. Before we let you go, I want to go over just a couple of other programs about the Crohn's and Colitis Foundation before we call it a night here. So again, this is Kathleen Waite with Crohn's and Colitis Foundation. And the mission of the Crohn's and Colitis Foundation is to cure Crohn's disease and ulcerative colitis and to improve the quality of life of the children and adults affected by these diseases. So that first part of the mission is research. It's funding the most promising research all around the country, and the most promising research. More than $270 million has been invested, and CCFA has played a major role in every major scientific breakthrough in IBD. The IBD Help Center is staffed with information specialists who are standing by to help direct you to the information or resources you're looking for. You can call, email, or live chat with them. Education program. CCFA hosts in-person and online education programs to help Crohn's disease and ulcerative colitis patients and their loved ones understand these diseases and how they're treated so that you can take an active role in your health care and make informed decisions. Check out our website for upcoming events and archives of past educational programs held online. The Power of Two is a program that connects those seeking support with volunteer mentors who have gone through similar experiences with Crohn's disease or ulcerative colitis. The two speak on the phone or by email. You can participate to request support or volunteer as a mentor at ccfa.org and click Find a Support Group. Camp Oasis is the premier support program for children and teens with Crohn's disease and ulcerative colitis. At Camp Oasis, the focus is not on the disease, it's on having fun, building confidence, and making friends who can relate. Take Steps is a community event that brings together patients, family, and friends, and healthcare providers to raise funds and awareness. Find the walk in your community at cctakesteps.org. And lastly, Team Challenge is an endurance training program that provides professional coaching and a supportive team to help you train for an endurance event. You can run, walk, cycle, triathlon, while you fundraise for cures for Crohn's disease and ulcerative colitis. You can learn more at ccteamchallenge.org. And with that, we will call it a night. Thank you all so much for participating. Thank you to Dr. Afzali. I hope that you found this beneficial, and hope to see you at future Crohn's and Colitis Foundation programs.